Can everyone hear me okay? Yes. Good. Right, so we'll mix things up a little bit. I'm going to come around the far side. So, first of all, to Mark, it's a pleasure to be here and speak about something which I'm quite passionate about. Not because it's my career, but so I'm a lecturer in ergonomics at the University of Limerick, and I suppose there's two strings to my bow, in the sense that one of it is physical ergonomics and workplace injuries. The second one is human factors in medical device design. So this is kind of half of my research area, but one that I've been quite active in now for quite some time. I also do some consultancy work. I'm not looking for any more, I'm flat out, I have only a small amount of time, but I have an amount of experience from industry, and including in legal cases. So I suppose in the course of my presentation I'll have some examples from my research studies, some from my industrial ergonomics work, and it's also some from some legal situations, and I'll try and kind of give you some of my insight. The reality is in organizations you spend a tremendous, or either you come into organizations or as contract or as working as an employee in organizations, you spend a tremendous amount of money on training and other preventive approaches, and quite often we don't get as much impact as we would like. So the title of my presentation is Effective Ergonomics, What is the Recipe for Success? I'd love to say I could cover in 1 hour absolutely everything that you needed to do in order to have 100% effectiveness when it comes to ergonomics, but we've got to remember we're dealing with the human body. Every body is different and everybody behaves differently, and these are things that we're trying to control by other people, that is us in training, etc. So it's complicated, but we'll do our best. Right, so let's get the show on the road. We're going to give you a little bit of kind of some pointers. So there's 7 points, so you get a feel for when you're coming close to the end. If you're asleep, I'll use the laser and point into your eyes to wake you up and stuff. So we'll get the show on the road. The first point is, what is ergonomics? Many of you know, we'll just take a moment out. Of course, it's a mixture of two words really, ergos and nomos. So the Greek word work and laws. So we think of the laws of work. Now ergonomics is a lot broader than just workplace design, but for our interest here today, we're mainly focused on physical ergonomics or workplace injuries. And so I suppose sometimes if I'm at a wedding and someone says, so what do you do? I say, well, I'm an ergonomist, and say, you're an economist, and you kind of go, no. So this is the laws of finance, we're the laws of work. But what drives strategy in companies? And I think earlier today we heard some interesting comments about managers. And we can look at managers and say, well, managers are making the wrong decisions, they're not taking us serious. I think as long as we keep on that strategy, we're on a losing track, because it's our job to educate. We educate workers, but we also have to educate managers. Managers have many different things pulling and dragging out of them, and have quite often a financial target to meet with their business. But in my experience, when you actually present something to a manager in manager speak, they buy in and they think, well, that makes sense. Okay, there's a moral obligation, but also if you can make a case for a financial obligation, I think it helps we sell ourselves better than purely driving on its own the social or moral issue, which I don't mean to water down in any way or undermine. What I'm saying is, put on your hat as if you're the manager and you're trying to understand the way they think in order to get ergonomics high on their agenda, to get that support that we need. We heard many times today the importance of management support, and we hear it across many presentations. Achieving that is difficult, but yet the people we work with are quite often the workers. Okay, the definition of ergonomics. I'm going to cut to the chase. This is the official one from the International Ergonomics Association. So we're looking at interactions amongst humans and other elements of a system. So what that's also pointing to there is we quite often think of a worker doing a task and they get an injury. But it's actually teams of workers working together in a working organisation, etc. So it's actually a lot more complicated. If there's a court case and a worker gets injured lifting something, it quite often seems very specific to the person and the box and the injury. But it's actually a larger picture. Indeed, many of my predecessors today have mentioned the multidimensional nature of the issues we're trying to deal with. I've highlighted a couple of points in red that I'm going to come back to later. Okay, so it's a profession, mention of theory here as well. So principles, data and methods, ultimately to the design of work systems to optimize human well-being. This is our safety and our moral objective, and something that's very close to all of our heart, preventing injuries. But there's this thing tagged on the end, overall system performance. We'll come back to that later, and I suppose just before we leave this slide, we should recall that ergonomics was actually, we'll say, born in industrial engineering primarily, and it's quite a young science. So it's quite at home when we look at work systems design. So that's the first part ticked off. Okay, so the second point is what I call the economics of ergonomics. And this is where I think we need to actually look more at thinking the way managers think in order to sell to them what is our objective. When we look, Frank earlier on today presented some data in relation to the burden and frequency of injuries and what they cost. We know that there are tremendous costs. Quite often companies tend to, they hear and they might see something in the health and safety review about our worker getting a cost or compensation for an injury. The reality is the actual cost to businesses. They might think of they have 100 employees with one worker about €50,000 on a case. But the reality is they have a lot of other workers who are maybe experiencing very low levels of symptoms of RSI or injuries. But they may, their performance might be compromised by 2% maybe, 1%. But if you were to put a value on that 1 or 2% and have a higher output by 2%, you can put a tremendous value on that too. Okay, some other data I mentioned here, this is a good number of years ago, but I felt it was interesting as well in the context of today's talk, in terms of what they were seeing. Now, the wrong problems report on medical certs. That comes with a pinch of salt, but either way, back injuries and pain and stress were the most commonly cited problems on medical certs in relation to absenteeism. And of course, we had this important study done a number of years ago that occupational illnesses and injuries cost in the region of 2 to 4% GNP. This is a phenomenal figure, but it's actually not at all unusual across developed nations. But it just does describe the burden of what we're dealing with. So I'm preaching to yourselves, even though you probably well recognize the impact. So, of course, ergonomics is somewhat different to other areas in health and safety where we're dealing with workers' injuries, because we're really looking at injuries which quite often develop over a period of time. So here's a couple of acronyms that we come across in literature. One I tend to use a lot is MusculoSkeletal Disorder, or work-related MusculoSkeletal Disorder. The RSI one is quite commonly known, and there's a number of other ones here. But I suppose what is common across all of these is there's a kind of a cumulative element. Something is done for generally a period of time. There's probably one exception. That's where a worker lifts a particularly heavy item as a one-off, and it's something that's particularly heavy. Dealing with patients are very heavy, but quite often in that situation, someone is doing the task for a number of days, weeks, months, years. So there's a cumulative exposure there as well. So they're a big problem. But when we think about the cost, quite often people, and in company as well, and managers, the biggest fear probably is, in this respect, is that something goes to court and there's a payout and there's a bit of higher insurance. But if we just look at the actual costs, I suppose for every direct cost that we have, and this is borne true by from some studies in relation to ergonomics and occupational health, there's quite a number of costs that are never realised. No one writes a check for them per se. The manager doesn't write a check. So they sometimes don't realise they're losing this one. Okay, our direct costs are up here. Here are a number of our indirect costs. I'm not going to go through every one of them, but I think we can all relate to the fact that we have a worker, they're experiencing an onset of these problems over a period of time. It means that their performance is reduced. They may be working targets. They might be missing those or not achieving their higher targets previously. There could be quality problems because they're finding it more difficult to do the job. Maybe we have to actually recruit our workers to take their place after getting injuries, so we have to train someone else. There's reduced output while our workers getting up to speed, etc. So it's estimated that for every €1 in cost we're dealing with, there's approximately 4. Now these are very rough figures, but suffice to say that if we prevented these injuries, we'd probably have a lot greater saving than just purely worrying about the compensation cost. And of course that feeds into our philosophy of prevention. Okay, it was interesting, I've heard it twice already today, the term presenteeism, and this is a term which is relatively new, I think, and I think it's quite interesting. Well, Absenteeism is the one that we're quite familiar with, when the worker is off work because of an injury. And we have the various costs that we kind of have totaled up there. Compensation costs is only a fraction probably of those. But presenteeism is where a worker is at work and they have early onset signs of symptoms of an injury. And there's two sides to it. There's one side where the worker doesn't realise that the symptoms they have is work related. There's a civil matter there as well. Separately then, think of through the, especially like a recession, companies downsizing and a worker's got a bit of lower back discomfort or shoulder neck complaint, or an office worker. They're thinking, I am not going to make any complaints about this. I'm not going to stick my head above the parapet. I want to keep my job. There can be an element of that. It doesn't have to be in recessionary times either. Or the other side is that sometimes workers think, oh, sure, I'll shove it off. You know, it'll go with time. Whereas we know from treating these type of injuries, you catch them early on. You treat the worker, you change the work, things should revert back to normal. So this is presenteeism, and this is a problem for us. So going back to the ergonomics, the economics of ergonomics, this brings in this idea of system performance in terms of where we see the other benefits accruing from interventions over and above purely preventing injuries. Now, this scale is a little bit confusing, but bear with me a moment. So if we take a particular case study that we have, and I suppose a lot of my work centres on manufacturing type work, so we'll take an example of a production line, and we have some injury complaints amongst some work areas. So we have a situation in a work area where we have some injury rates and we want to go from high to low. So we want to reduce the frequency of injuries. But the other side then, in the definition of ergonomics, mentions this idea of system performance. Now, performance can mean different things to different companies. We'll simplify it and call it, say, productivity. So we have either low productivity, a problematic workstation, and we have the idea of having high performance or higher productivity. So we always aspire to having higher safety and higher productivity. That's never really going to change by way of our continuous improvement philosophy. Of course, where we want to always be striving to is up here, isn't it? We always want to have lower injury rates as well as achieving higher performance. If we do that, we're ticking many more boxes in our companies than just improving safety. And we'll probably find they'll be more receptive to giving us more budget. And we have also the input from workers. Workers see the change as well as management. So it's kind of a win-win situation. So some might say, if you stay down here, we have hazardous workplaces, injury rates not changing, poor workplace performance. Up here, it's just, it's good ergonomics. We're improving the worker safety, but we're not increasing the productivity. So it's worker protection, and that's important under our obligations under legislation. Oh, someone might say here, well, this is just an industrial engineering improvement or productivity improvement. We haven't changed the work safety. Up here is where we really should be aiming. So we should be achieving a reduction in injuries and also ticking some other boxes that target performance in the industry. It's not as easy as this, but just quite often we are doing this and we probably don't realise it. Here's a couple of examples from the literature. A famous text actually, which coined the phrase good ergonomics and good economics, one by this chap Hal Hendrick in the US, and he gave some interesting examples. I won't go into these, but I will this one here because I really like this one. A chap by the name of Göran Öklund over in Sweden. So he gave an example actually from, I think it was Volvo production. Another production line would actually start off as a quality problem, where the trim of the cars were getting scratched on the inside because guys were down using screwdrivers, trying to put on trim, they were getting scratched. And at the end of the production line, the X number of cars coming off and they had to strip off the parts and refit them. And when they did a root cause analysis of why are these problems happening, they soon discovered actually the workers were in very difficult postures. The tools were unsuitable, they were heavy tools, they were clunky, they were slipping when they were doing it. They also had to discover they had previous injury complaints. So they redesigned the process. They improved the ergonomics and they also eliminated the quality problem that they had. So hence there was a big financial saving. So we can quite often see that ergonomics problems are also related to productivity and also quality problems. So this chap, Jan Dul in the Netherlands, gave some other examples of small companies where they're quite short on space, and as part of lean improvements, they used ergonomics as well in the interventions with the workers, and they got very successful benefits. These are some data actually from an Irish company, and without mentioning their specific sector in any more detail than say it was food production, and their name or anything. Ultimately, it was quite physical work, repetitive work that they had, and these were some data that they had from the occupational health department in terms of referrals for treatment. These are not court cases or indeed full-blown injuries. These are ultimately referrals to occupational health and safety for some treatment. So upper limb disorders, lacerations, etc., etc. So it was highly repetitive work. So what they found is, I was delighted. I didn't put together this chart. They had it done already because one of the occupational health nurses had done, I think, a master's of occupational health. She had the data and she was collecting it as she was going. Their decisions on where they targeted their efforts were very well informed. Anyway, so we can see that a lot of problems with upper limb injuries, lacerations and back problems were the top three, and some lower limb disorders. So, bringing back in economics, this chap here is Pareto. He was an Italian economist, and of course he came up with this idea of 80-20 rule. And I suppose when we look at workplaces, we quite often find in relation to musculoskeletal problems that it's not an exact figure, but 80% of the problems are due to a relatively small number of the workstations, for example. So if we take that principle, especially when we're doing an initial intervention, quite often we find that quite quickly we can determine what are the actually most problematic workstations for our initial target. So we can look at that from an ergonomics point of view as well. So when we looked at these data here, we actually discovered that all of these, the vast majority of these upper limb disorders in this company were actually occurring in one specific department, which made things a lot easier for us. So that was very helpful. So we're going to do some more detailed analysis on that. But I'm just going to look, and as you will see my back of the envelope, estimates of some costs. Just try and give you a feel for what were the costs associated with those problems that they had. Now a lot of these, they were very progressive, but it was tough work that the workers had to do. So if we look at what are the estimate of costs, so here we go. Top four categories, say 125 injury treatments, say €250 direct in terms of treatments, in terms of either referral to the company doctor, the physiotherapist or the occupational health nurse and some other costs. 250. These are not, there's no mention of legal matters or litigation at this point, just purely treating them. So that gives us a figure of maybe €31,500 in that 1 year for dealing with those. But if we're saying that approximately the indirect costs are 4 times that, then what we're saying is we're potentially looking at a figure of over 100 grand for those workers. So the company are thinking, we had 125 injuries, but we sorted them, there wasn't an issue. All of a sudden we start to get a rough figure that we're losing out quite a lot of potential revenue, or we're incurring a lot of indirect cost. These are quite rough figures. Let's just take another one. This is an interesting one that I came across actually. All I can say here is that it was a high technology sector. I can't give too much more detail because it is confidential and I don't want to give any kind of a flavour for the actual company itself. But suffice to say that it's a high technology sector. Equipment used is quite expensive. They had a problem with workers over-tightening a certain component. They had in the region of 30-40 of these workstations in the company. And I was talking to one of the maintenance engineers. He said, you know what, there's a particular device on top. Yeah, we replace about 2 of those a month. He said, the product they're making a lot of money out of it. But ultimately, they didn't really bat an eyelid that they were costing 16 grand per component when they were replaced. And it was just seen to be an issue with these machines. They almost expect it. So I said to him, a rough estimate, they were spending 384 grand on replacing these components because the workers were over tightening them. Now, I was brought in because they had a completely separate issue with workers over tightening them. So it was an ergonomic problem, and we came up with actually a reasonably straightforward solution that could retrofit over these machines that would resolve the issue with over tightening and also prevent the workers from applying too much force. Ultimately, the workers felt they had to tighten this thing really tight, and in doing so, were straining their hands. So anyway, it was a fraction of this, the design implementation, to help resolve the ergonomic and also their maintenance issue. So there we go. So that's a nice example there. So I suppose it plays into this idea of true ergonomics and trying to get a win-win. Now that's great if you work in a company where they really have a wonderful philosophy as we aspire to, that you don't have to do a high sell in terms of convincing them. But quite often in my experience, we need to, because companies, a manager is someone is saying, well, I need to get a new 5-axis CNC machine that's going to cost 200k. And the boss is also looking at you saying, well, I want to do an intervention, and over 2 years it's going to cost 50 grand for a variety of reasons. So we sometimes have to sell our case, unfortunately. Sorry, Frank, you shouldn't be hearing that stuff. Okay, so I suppose that just brings us then in terms of, you know, recognising the risks. And I think when I get involved in companies and doing work, quite often they come to me and to get involved, and sometimes I leave and I think, they brought me in, they've identified the problem, they know what the problem is, and it just seems, I think, that this area of ergonomics, they felt it was something that they couldn't do the risk assessment themselves, and that it was just something just completely alien, that they were completely outside their comfort zone. When quite often, it turns out they knew the solution and they were looking for you to tell them what it was almost. So anyway, here we go. So Birgit Greiner before me has mentioned some of these risk factors in terms of how they're linked to repetitive strain injuries and MusculoSkeletal disorders. Ultimately, with high force, well, muscles are overly active and there's a fatigue effect, or tendons are repetitively strained. Poor posture adds to those strain in the muscles and tendons. Repetition, when there's highly repetitive tasks, and when we think of repetitive strain injury, some people sometimes think it's purely about screwing widgets into something on a production line. But actually, manual handling task, if I might be lifting 5 kilos on a production line from a pallet, from a workstation onto a pallet, and it's 5 kilos and you're thinking that's safe, but actually, if that is done at sufficiently high repetition, it will not be safe. So, moving on then, rest and recovery is an interesting one in the sense that when we're having an intervention, these are the main risks, the priority ones, and these two as well. Rest and recovery is how we sometimes can alleviate the fatigue effects. Interestingly, in court cases, it seems really obvious to a judge and senior counsel when you're looking at a task. A plaintiff claims, I got an injury doing the task, I did this task all day long. Well, the first thing says, could you not have rotated the task? Now, I would be going with some of these up here, get the task right first of all. But anyway, rest and rotation are critically important, and it is one way of addressing fatigue effects, but it's not the panacea. Vibration, we know, is directly related to vibration by finger, but also carpal tunnel syndrome. And my predecessor, Birgit, has mentioned quite elegantly, actually described a number of aspects in relation to psychosocial risks. So, I suppose the key thing is, these are the same risk factors that we're going to have, whether it's lower back, shoulder, neck, or upper limb injuries. That's good in the sense that these are the main risk factors we have to keep an eye out for. So the first thing is to recognise them. The work-relatedness of these, well actually, there's quite a wide body of data now that demonstrates the work-relatedness. And up until recently enough, it was actually questioned. And I suppose if you think about it, think of the idea, what causes noise-induced hearing loss? Well, it's obvious, it's noise, and it's a very mechanical factor that's directly related. But if you're dealing with carpal tunnel syndrome, the trouble is there are many factors which come together that have an effect, which sometimes makes it more difficult, in especially legal situations, to be able to say beyond reasonable doubt that exposure caused that injury with no other effects overlapping. But anyway, the scientific evidence is now getting increasingly stronger, it's well recognised, and we have a wide breadth of methods arising from those scientific studies that we can now use. Okay, so moving on, I suppose, well, this is actually a summary of a very important review that was done in 1997, quite a number of years ago, but it's still widely referenced, and there have been others since. They were having this kind of we'll call it a public debate in the US at the time. I think it was President Clinton who commissioned this study, actually. There was vested industry groups and there was worker groups. The industry groups were saying, these musculoskeletal disorders is all a load of hash, really. Whereas the worker groups were saying, work-related musculoskeletal disorders are a problem and they're caused by work. So they set off a scientific committee to actually do a review. The long and short of it is, they went off and reviewed quite a number of scientific articles, and in relation to these body regions, they came back and they said, well, what was the strength of the evidence of each of these relative to the injuries? Now, things have moved on a good bit since, but it was quite clear that for some of these, it was very clear the most important risk factors. So I'm just going to summarise by saying the scientific literature and the work-relatedness of individual risk factors and these injuries are quite clear and well established. There are pockets in that, but it's quite well established. Just to complicate matters even further, and I think the noise example is one where we can see this direct cause and effect relationship. But when we're dealing with musculoskeletal problems, we heard earlier, and I'll repeat now as well, this multifactorial element to it. And come back to the idea of a person injuring their back lifting a box. It's a lot wider than that. So this is a model, conceptual model describing the various factors that come together when a worker might experience, what they go through and experience injury. And just bear in mind that this is occurring over a period of time, right? We have the person over here in this box on the right. We have the workplace that they're working in. So if a person is doing a task and the task is in the course of causing a musculoskeletal injury, the person goes through a biomechanical loading. There's an internal response, physiological response by fatigue. If it's continuous exposure, there's internal tolerances, there's mechanical strain in the tissues, which might result in fatigue in the tendons. If it progresses, they experience pain and discomfort and impairment and disability, for example, carpal tunnel syndrome. In parallel, there's a number of things that might be happening and helping to accelerate that. There's external loads, that's the tasks that they do. Organisational factors, the arrangement of work, the intensification of work, and also then the social context in which they do the work. So I suppose these arrows each indicate where there's interrelationship going on between some of these factors that are increasing or mediating some of what's going on over here in the body. On the right then we have individual factors. So what's actually involved in a person experiencing an injury is actually quite complicated. But we want to prevent that happening. So I suppose looking at this idea of cumulative trauma, I remember speaking to a lady at a conference a number of years ago, and she had quite severe carpal tunnel syndrome, and she was a member of an advocacy group. And she recounted to me how she experienced her onset of carpal tunnel syndrome. Nothing changed in the job. She was a secretarial worker in a company, doing the exact same job, intensive secretarial work. And ultimately, there was one weekend where the boss, she had something to do for Monday, and the boss ultimately said, I have to have it done before Monday. And ultimately, she ended up working very flat out through a Saturday, and she just got this sudden onset of the injury. Now, it's not that the injury only occurred on that Saturday. It was kind of the straw that broke the camel's back. She was being exposed to that over a period of time. There were some symptoms that were presenting over a period of time, but she tolerated them, shook them off, so to speak. Right. So it's repetitive. It's not overexertion. Ultimately, micro-trauma. Like when you do work, you will experience some fatigue. That's to be expected. But quite often, you go home, you shake it off, there's recovery. But if you get injury, many people then become sensitized, which means that they might recover from the tendinitis, but if they're exposed to the same task again, it flares up straight away. So this is an analogy in relation to manual handling, I suppose, and it is quite interesting in the same context as that lady with carpal tunnel syndrome. Let's just say this is my tolerance, my strength of L5S1. Say I have 6,000 kilonewtons of compressive force or resilience to injury. And this is my spinal loading in the course of the week or the day or whatever it is. I'm doing the exact same task, but it's with time, because of the fatigue, my resilience to the injury decreases. It's not that I all of a sudden went off and lifted 4 boxes more than I normally would in one go. So it's this cumulative exposure, and we need to be kind of cognizant of that. Put on top of that then these psychosocial risk factors and the effect that they bring in on top of things if they're present. You don't have to have psychosocial risk factors present to cause a problem, but they will add to the strain in the person's body if the negative combination is present. So we might have ultimately a response in the body, an endocrinological response to the stress, which can further stimulate physiology, which also overlaps with biomechanical loading, which can further increase the risk of strain for musculoskeletal disorder. So Birgit mentioned also the job strain model, and we know already that in particular the combination of tasks that we want to avoid is high job demand and low decision latitude. We did a very interesting study about 10 years ago in a company. They had, we were studying shift work, and we were doing a psychosocial risk evaluation, and ultimately we started off with the theory that the night workers would have worse occupational health issues than the permanent day workers in this particular company. When we did the psychosocial risk evaluation, we got the complete opposite. There was less supervisors on the night time, and ultimately the workers had greater job control. On most of the company, they still did their job and did it very well, but they had more job control. So anyway, we want to avoid the high job strain scenario of high job demands and low job decision latitude. Okay, so we recognize the key risks that we should keep an eye out for. Next thing, we need to evaluate the risks. So I suppose in ergonomics, the key message here is that we look at what we're expecting of the person and their abilities. And indeed in legislation, it should be reflect the person's ability who's doing the job. Right, so we need to do some kind of an assessment. We do a risk exposure analysis of some form, and we compare it to the resilience to injury. Now, quite often we have to rely on kind of population recognised averages for males or females doing the task. We do this assessment. If there's not a problem, what do? Do we either change the person's abilities? Well, that involves changing the work. We don't really advocate doing that. We change the work. So we go through this cycle until we get to a situation we're happy. So what's the shape of those assessments? Well, we have either qualitative assessments, which are quite often checklist based, or based mainly on subjective comments, or numerical analysis. Now we tend to find that there's a lot more of the qualitative checkpoints that tend to be used, not so much of the detailed numerical biomechanics analysis. This is quite specialised and will probably require an external agency to do it for you. But we have quite a number of qualitative type checklists which competent health and safety persons can use to get a reasonable feel for those exposures and whether they comply with some recommended guidance. If you get to a situation where you recognise that it's beyond your area of competence, you bring in an expert who does have the more detailed competence if necessary. But actually, just going back to that for a moment, quite often you're in that situation and thinking, now, okay, there is a problem with the load. I've got to say that there might be a problem. Do I bring in the external agent to actually do a further analysis, or do I just go back and rectify the job? You have a field that forces the problem. You bring in mechanical aid. Problem solved. Right. So I suppose in that vein that we have many elements of guidance. The Health and Safety Authority has some very good guidance in relation to risk assessment. We won't go over that because many of you are familiar with it, but in terms of the stages we can go through. By way of guidance, the Health and Safety Authority have very practical guidance in relation, especially like to manual handling. And there's also similar guidance that was associated with this from the Health and Safety Executive in the UK. So don't be shy of using current resources to get a feel for the risks and whether they're acceptable or not. This is just one example. This is the type of detailed analysis that I can do with some either software or other methods to do a nice lower back loading for a particular work situation. I probably tend to use it more in an investigative situation, but sometimes actually for workplace design as well. Birgit also mentioned earlier the psychosocial risk evaluation methods. I have to say that the work positive method, which is available on the Health Safety Authority website, is very practical. There's a printed version questionnaire or an Excel sheet. You can use either one, pop your scores into the Excel sheet they give you for free. You get a chart like this, and you know pretty quickly whether a particular worker or a group of workers, how they're achieving in relation to each of these dimensions of the psychosocial risks. Should you do a psychosocial risk evaluation on absolutely every single worker? My understanding and the way I would look at that is that I wouldn't imagine that you would. There's probably two strategies. You might decide as part of your proactive activity each year to sample groups of workers to get a baseline, or if as part of your normal risk assessment anything sets off a trigger that there's possibly a need to follow up, then I would certainly, it's like an ergonomics analysis. It's normally your general risk assessment that would spur the decision to do the more detailed assessment. Right. I suppose in relation to doing your analysis, the good news is that in recent years, especially the last 10 years, there's been a good number of international standards available which help to, I suppose, clarify the situation. One thing that we will note, however, go back to noise or vibration, it's quite prescriptive what you need to do to test. The international standards in ergonomics say this is the general approach. These are sample evaluation methods you could use, but ultimately, because every work task is so different, you have to decide which method is still suitable for which task. But certainly those pieces of guidance are very helpful. And I think especially I find in particular the large multinationals are particularly happy and reassured when they have some reference to an international standard. But maybe it's something that if you're having difficulty in persuading someone that or your own company to actually make a change, if you're able to say, well actually, there's an ISO standard in this space, and my understanding is we're not meeting it. That is also something which can be helpful to you in convincing someone to participate in your intervention. A couple of examples there that are very helpful. So the first one, general standards in ergonomics, anthropometric data. These standards have been around for quite some time. But manual handling in particular, there's been a number of methods. Now they're collections, so like these methods present the likes of the MIEHF lifting equation and some other methods. We're around for quite some time. This particular suite of standards is quite good as well, and it actually comes in under an IS standard, safety of machinery, but ultimately, especially when you're looking at repetitive work. So if you have repetitive work and you're looking at upper limb repetitive strain injury, these are the standards that cover it, and the previous ones, especially in relation to manual handling, and there's another one in relation to static work postures. Moving on then, how do we achieve high impact? So we have a finite budget each year that we have to spend maybe on our activity preventing these problems. How do we get the best bang for buck? Well, I suppose it's when we look at the overall burden of musculoskeletal disorders. Now let's just consider this is a timeline, and this is the burden. We might think of it being the frequency of injuries in our workplace, but ultimately a number indicating that the scale of the problem that we have in our group of workers. The last presentation actually noted as well, people come to work and they bring a personal element to the degree of risk as well. And certainly I'd never use it as an excuse to indicate that you should just say, well, that's the person's problem. It's just part of, it can be human variability. Maybe it's the example we had earlier of the aging process and the degeneration. So some people have an underlying susceptibility or a condition. So there's a non-work element possibly. But then there's the actual physical element. There's the task I have to do. There's palletizing operation on a production line, or I have to assemble components, or I have to do, I'm a secretarial worker. So there's force, repetition, and posture. These are very mechanical elements that we can relate to, especially if you have a biomechanical model even. It's very easy to relate exposure and strain. So what we heard today is that the psychosocial element is also critically important. We can distill that down into job demand and control, say for example. So let's just say we have a particular problem, or you've been brought in as your new health and safety manager of a new company, and you've set as a target to address some of these issues. Quite often when I'm brought into companies, there's a work task or a workstation, or there's a person who's got injured. So it's very specific. That's quite often targeted around posture or repetition problems at isolated workstations. So it's quite often reactive with a limited impact. And quite often the overall burden will at best reduce and stay at a level lower. But really, it's not unusual, it might probably creep back up. Level of impact, quite low. The reality is, if we really want to have a good impact, we have to be looking at a more wider breadth of the fact that the actual risk factors are multifactorial. We know that they're cumulative and they creep up in time, so there's an early warning signal there we should be detecting as well. And overall, we actually want to apply continuous improvement and continue to lower that burden. Now, how we measure that is another thing we'll come on to in a moment. But this is using a more proactive approach. Of course, preventive approaches are what we preach, but how do we achieve that in ergonomics? Well, of course, if you're looking at a work task or workstation, these are common phases that we'll typically go through. And I suppose the chance for design changes we'll put on the vertical axis here. Once the workstation's up and running, we can make changes. It's very difficult. People are very resistant for a variety of reasons because you're getting the widgets out the door. We can make a lot of opportunity and changes here quite easily. But the cost of changes follow a different curve. The cost of changing a workstation height early on is actually quite low. If it's up here where you're making items, it's a lot more expensive. You have to take production offline, and there's a variety of costs. Surprise, surprise, we say there's low options and high costs for changes here. Preventative ergonomics is really positioned back here in the design phase. Corrective ergonomics is where unfortunately I'm brought in, but that's where often it will happen. So we know that it should be happening somewhere here and back. Even here is probably fine. The reality is you quite often need a good skill set. How do the big companies do it? I've done a lot of work with some of the big automotive companies across Europe, and they'll use a computer-aided ergonomics package. On the right we have actually there was one package developed in Europe by the big companies and one in the US. This is an image of the one from the US. It was called Jack. Then they brought in a female model into it and they called it Jill. So anyway, this is Jill. So this is an example. It looks really cool, nice CAD drawings and so on. They can do biomechanics analysis. On the left here we have quite a detailed biomechanics model. I used some of my research. So it's not surprising in these situations we can do analyses and we can make changes. But that's if you have access to these resources. These are expensive, they have a big skill set. That doesn't mean you can't do them. If we just take, we actually held a seminar a couple of years ago, and Frank and some colleagues assist us in recruiting some companies to come in, and they presented some really nice examples of how they implemented ergonomics changes through low-cost methods, achieved high impact, but using the right approach in terms of mainly preventive. Okay, we had one biomedical company. The trick that they had that was really interesting, they involved the workers, surprise, surprise, but sometimes companies are hesitant to do it. But they went off and they just used really basic materials to develop a prototype of the workstation in a vacant part of the factory before they introduced it. Got some workers in, trialed it out with some piece of equipment, and they were able to easily make some changes. Didn't involve any fancy software. Another couple of examples, these were corrective ones in window manufacturing, some really practical approaches to reducing risk by the company. Another example from a pharmaceutical company where they looked at behavioural safety changes. The tricks here as well include that the worker input was critical. So, I suppose ergonomics in big production industry. Preventive approaches, they look at investment costs, they look at trying to lower absenteeism, presenteeism, but they do need a big in-house skill and software. But you can do it on a low budget by not being afraid to prototype the workstation, get the workers involved. Of course, senior management is quite crucial, as we're well aware. So I suppose that we're coming close towards the end of my presentation, and I just have a number of slides to try to kind of give you some further pointers. The Health and Safety Authority have released a number of documents over the last, in particular 2 or 3 years, that are really very helpful. They're really pitched towards practitioners, very, very well, I think, structured and so on. So one is, I think, released last year, if I'm not mistaken, available on their website, in relation to managing musculoskeletal disorders. This is just a snippet from it in terms of main elements for preventative policy in relation to these. You're doing some of these items as it is quite often, but it's really looking at them from a preventative point of view. Like, you're probably doing great work in training, but in terms of how we look at accidents, for example, maybe we need to look at those slightly differently from a preventative point of view. So here's 2 separate documents that you can access from the HSA website. Guidance in Prevention of Management of Musculoskeletal Disorders. This one, a recent one as well, in relation to manufacturing industry. This is an old textbook from the International Labour Organization. It's about 80 or 100 pages. Ergonomic checkpoints. It's got a nice collection of practical examples of applying ergonomics. It's geared towards industry and practitioners. It's now freely available on the web, actually. They released it recently as a PDF. So if you Google ILO ergonomics checkpoints, you can download this as a PDF. It has a number of checklists as well in there that you could use to do your ergonomics, basic ergonomics analysis with. I mentioned the Work Positive tool, so that's covered already. It's up on the HSA website if you felt you wanted to go down that route. So we're on to the very last section. So, I decided to add in some slides in terms of kind of maybe sharing some of my experiences. I've called it keeping your eye on the ball. Quite often we're doing a lot of activities, and sometimes it's not a while later we realise we did a couple of things by mistake and we lost out on opportunity. The first thing I would say is actually looking at leading versus lagging indicators. You could actually have a whole seminar on this on its own. If you're looking purely at injury rates, you're looking at the wrong thing. Yes, look at injury rates and lowering them, but you actually need to be looking at what we call leading metrics that we should be using. Now, they're going to be different for every industry, but maybe they are number of people who receive refresher training. Maybe it is number of complaints. Now, number of complaints can seem to be positive. If you're encouraging your workers to report problems, you could see it as being a positive score. You might have, you might do discomfort surveys. There could be a variety of ways you look at leading indicators, but ultimately think of it. We're saying these cumulative trauma disorders are occurring over time. So there's a warning light in there somewhere for these occurrences when they occur. So consider that. I'm not saying don't look at purely injury rates, but looking at leading injury statistics as well. By way of example, actually, some workplaces use the pristine manual handling evaluation method, which is quite common in the UK, where you actually do checks on your workers' lifting technique. You do them in the course of normal activity, but also they have auditors who come in once or twice a year and also do it. So you could have as a target, last year they came in, they gave us a score of 88% compliance. We're actually going to get that up to 90% compliance in the next year, for example. These are type of things we're measuring that we could use. Okay, think prevention. And I suppose develop a musculoskeletal disorder prevention policy. I think this is from Schedule 4 of the Act. So it's generally in relation, it recommends the development of an adequate prevention policy in relation to safety, health and welfare work. I would go so far as to say, for your industry, if it's suitable, have a specific one, it might only be 1 page or so, on your preventative policy for musculoskeletal disorders. Training is critical. There's a whole issue around the efficacy, and we're aware of that. That's not to say you shouldn't do it or can't do it. But what I would say is, we have what's critical to quite often include. Now, where I actually come across this most is when it's part of investigation in relation to a court case. It's one of the first things I'm going to look for, whether on the side of the plaintiff or the defence. I want to say, I'd like to see the manual handling training. Okay, the sign-in sheet is the obvious one. I want to see the training material the person was trained in. What were they told to report? Were they advised to show symptoms, early onset of symptoms of musculoskeletal disorders? Were they told what musculoskeletal disorders are, what the symptoms are, and that they should report them at their first onset, whether they think they're work-related or not? There's where you're actually going to have one element of capturing things. You're doing 2 things. You're either CMA, cover my ass, I can use it, it won't get you off the hook. Or you look at it from a positive point of view. You're doing training anyway. Build it in there such that people will use it and they're aware that you should report problems. Quite often workers who experience injuries and they're going through a court case, it's not at all unusual to say, they were experiencing a problem for the previous 6 months, they didn't know it was work related and that they should report it, right? And quite often it's a weak defence. The company says, we didn't train them. So anyway, moving on. As I've mentioned that point, training records. Okay, we have statute limitation 2 years, but ultimately a worker can bring a case against an employer. As I say, the clock starts ticking when they become aware that the work was work-related. So I might have been off work for a year with a back problem, but it was only at the end of the first year I actually became aware that it was possibly caused by the work. So you're actually 3 years down the line. So it would not be unusual, and because a court case would take a period of time to chug along, someone might come along and say, Joe Bloggs did a course 5 years ago. Do you have their sign-in sheet? Do you have their training materials furthermore? Right, so you keep these details, but it's just the importance of it. And of course the quality of the training material is critical. Risk assessments. The key thing here is that you provide them, you do them on all tasks, including if you do it on a task and it doesn't indicate a risk, it doesn't mean you don't keep it. You could be looking for that in 2 or 5 years' time. Obviously you want to motivate continuous improvement. I mentioned leading versus lagging indicators. Decide on what are the most appropriate leading indicators for you for preventing musculoskeletal disorders. Involve workers. Have your risk assessment and improvements, and of course there's many resources from the Health and Safety Authority and HSE websites that you can use. And the final message is, good ergonomics is good economics. Thank you.